Well, hello, everybody. It's nice to have you here. I'm glad to be presenting to you today. A lot of the material that we will go over will be things that a number of you already know, but I don't think it ever hurts to go through things another time. Some of it will be new information, I hope, but I hope everybody learned something. The one thing I'm always happy to present because I think of you all as listeners and all of us as therapists that are part of a big army of therapists all around the country and all around the world. And our job is helping people to live better and reduce suffering from each one individual at a time, one couple at a time, one family at a time, or one group at a time. And I see us all together in this giant army helping people out. So I'd love to be a part of that army, and I'm glad I am today. So what I'm here at Sierra Tucson. I've been the director of the Chrysalis program, which is a small program inpatient for those people who are too ill to be in residential treatment and yet not needing acute care psychiatric hospitalization. Qualifications: I'm board certified in psychiatry as well as addiction medicine. I am a somatic experiencing practitioner, and I'm midway through training in central motor psychotherapy. What I say is I'm not an expert in trauma, but a student and a learner. So, if I'm not an expert in trauma, why do I have anything to offer? And I think what I have to offer is I've been a psychiatrist for 38 years, and I've had a lot of experience working in a variety of settings. And what I really want to do is just share some information that I've learned over time that seems to make sense to me and has helped me in my practice. So that's what we're really about today, and I hope it's helpful. First of all, we always start with definitions. What is psychological trauma? How do we define it? Well, one thing I want to make sure that we understand is that trauma is not actually in the event, but the body's response to the event. And what I describe is a little bit different from what's in DSM-5. I say that anything that overwhelms our capacity to cope and threatens our survival, either psychologically or physically, is psychological trauma. The second part of the definition is trauma is an ancient Greek word, trauma, which means wound. So I think of anything that wounds our hearts, our souls, or our spirits is psychological trauma. So from this standpoint, all of us do experience some degree of psychological trauma in our lifetimes, some just much more than others. Now, I've tried different words for how to refer to people that I'm working with, and patience doesn't seem right because it seems a little bit opposite from what I try to teach, and that our folks have no real illness. So I've come to terms with the client, which is not the greatest term, but it's one I think that's the most commonly used. So I use that term to refer to the people that I see. Interesting thing is that developmental trauma and betrayal trauma is not in DSM-5. So I think DSM-5 is helpful in understanding some things and some basic definitions, but it's not sufficient. One thing I always tell everybody is that trauma is not a disease. It's not a disorder. So I tell people that I don't like the idea of post-traumatic stress disorder because it implies that you have a disease, a disorder, that you're sick, that you're ill, that you need to be fixed, that there's something wrong with you. And that is simply not the case. What the case is we have normal nervous system responses to traumatic events. And post-traumatic stress disorder is nothing but the failure to heal from the acute symptoms. So I look at it as a failure to heal rather than a disorder. What also takes place then is that we want to emphasize to people that there's nothing really wrong with them. I always say we have symptoms, we have interpersonal difficulties, but in the end, there's nothing really wrong with us. A lot of people with developmental trauma, betrayal trauma, early life trauma feel there's something essentially wrong with them, and they feel very shameful that they're guilty, they're defective, they're not able to be loved or cared for. And I think I like saying there's nothing wrong with you because a lot of people really see that as a big shame reduction statement that they really haven't heard. Now I want to talk about goals of therapist-assisted trauma recovery and therapist-assisted help of any kind. And I keep them as very, very little. And the main is to improve the quality of life and functioning in the world. The goal is not to have any particular therapy modality. The goal is not to have any particular things such as processing certain degrees of trauma. The goal is to improve the quality of life and improve functioning in the world. And anything we do to help our clients do that is what really makes a difference. So one of the things we do is we create a safe space for them, which allows us to do our other work. And we always take a mindful, not judgmental, affirming stance. Now, there are objectives that I see in terms of therapist-assisted trauma recovery. And these are one of the things that we like to see along the way that will be signposts that we are helping the client improve. So each session starts with really no agenda. The agenda is the client's agenda, and we try to tie things into other things we have talked about. But each session is not my agenda for the client, or I don't have any specific agenda for that individual session. What I'd like to see along the way is that they have some recognition that the trauma occurred and it's what we refer to as not my fault. We're looking for better regulations of emotions and the nervous system. We're looking for shame reduction. We're looking to decrease dissociation and somatization. We're looking for an increased ability to form and maintain healthy attachment and relationships. We're interested in improving mindfulness and self-awareness. We want improved communication skills. We are looking for our clients to experience and tolerate a wide variety of emotions and feelings, have an improved sense of self-esteem and self-efficacy, and the ability to experience a sense of aliveness, creativity, and joy. So these are the signposts along the way that I look for to see if we are helping the client make the progress that we're really looking for. Now I want to talk about some principles of therapy, and this goes for all therapies, and these are not my ideas. These are ideas that I've taken from Ron Kurtz, who is the developer of the Hakomi method, Pat Ogden, who is the founder of sensory motor psychotherapy, and Steve Hoskins, who is the founder of organic intelligence form of therapy. So these principles are, first of all, organicity. And what that means is that each living being has its own innate intelligence and an own innate wisdom. And what we do is when we tap into a person's own innate wisdom and ability, they heal. People know how to heal, but we get in their way, and sometimes our minds get in their way. Another principle is unity, and that is we're all in the same boat. We're all in the same space. We're not really different between client and therapist. We have things very much in common with us, as we're all human beings. And we say that although there are individual differences with human beings and there's differences in cultures, and there's always has to be awareness of cultural factors, we are essentially all the same. We also talk about mind, body, spirit holism, which is that you have no ability to talk about the mind without it affecting the body and the spirit. You don't talk about the spirit without affecting the body and the mind. You don't talk about the body without affecting the mind and the spirit. They're all three together. And what do I mean by spirit? I mean the ability to have a non-judgmental, present moment experience that allows us to feel that we're alive, that we're glad we're here in life, that we're doing something that is meaningful to us. And that I look at as spiritual aspects of improvement. There's also the principle of nonviolence. And people will say, well, we're not violent with our clients. Well, what this is referring to is a stance taken that we're not aggressive in any ways. So what I would say is I never confront clients. I think I help them clarify what is going on, but I never confront them. I don't tell them what they need to do. We look at choices and options. Also, if I have to set limits, I have to do so with a strong awareness that limit setting will always cause some degree of shame in the client, and I have to be aware of that. The other thing that's nonviolent is very little making of interpretations. Now, we're taught a lot to make interpretations, but I've told patients and clients quite a bit about things they like and don't like about their therapist. And one of the things that comes up is they don't like interpretations. They like Socratic questioning and the ability to figure things out for themselves. So what we're looking for is, I said before, mindfulness of present moment experience. That's where we can learn new things. Also, the principle of relational alchemy. This is a term that's used in central motor psychotherapy. And what it's really talking about is the alchemists were those who wanted to make something new out of something old. In other words, they wanted to make gold and silver out of other chemicals. What we find is that something new arises when we're in a relationship with the client, and both of us are changed because there's a joint interaction between both of us. Then we also look at the idea of empowerment, resiliency, and compassion. We want to look at what's right with the client rather than what's wrong with them. And another aspect of this is that we need therapist self-development. We need to continue education. We need to continue our therapy when it's needed and helpful. And we just need to develop overall as people. And that's, I think, a principle of therapy. Now, I'd like to talk about the Therapeutic Alliance, and that's what we're really talking about today, because it's the single biggest factor in bringing about positive change in the client. And this has been shown in a number of studies that it's not any specific form of therapy, but it's the quality and the strength of the Therapeutic Alliance that makes the biggest difference. So how do we improve that? That's what I want to be talking about today, is ways to increase and improve the Therapeutic Alliance. So one of them is we have to have positive regard that we have for the client. And what I tell our therapists here is we've got to find something to what I refer to as love in them. Now, Ron Kurtz in the 70s said something that I think is very valuable. He said, my first inclination when I see a new patient, he called him patient, is to find something in the patient to love, to admire, and also the heroic. And I think this is the way we have to look at our clients. They are heroic. They've gotten to us and they've survived. Many of them have survived a great deal of trauma, and they've survived life circumstances and are willing and ready to open themselves up and be vulnerable to change. So I think our first order of business in working with a client is to find something that we really admire in them and see the heroic in them, and that we basically love them. And by love, I mean treat the person exactly the same way we would want to be treated ourselves. Sometimes I've had a little difficulty with this. I've had one person I tell about that the first day I met them, I really didn't like them for some reason. I don't know why. Second day I met with them, the next day, I still couldn't find anything to really like in them. And it must have been my own prejudice or something. But I was really stumped. I thought, what am I going to do? I think I'm going to have to transfer this client. But then I realized that this person who had had many episodes of self-harm and was really self-destructive had never, ever in their life made a suicide attempt. And I thought, how heroic that you suffer that much, that you would engage in a lot of self-harm, and yet you're still fighting to be alive and never made a suicide attempt. So that was that positive regard that helped me to continue to work with the client, and we had a good working relationship. We also need the expectation by both the client and the therapist that healing can occur. We both have to believe that. Another thing is what's been found in a number of studies is that we go from a relatively low arousal to a high arousal in the session and back to lower than at the end. If a session is flat, either someone's disconnected or they're way high and way above the window of tolerance and never have any low arousal, then we don't get much done and not much is integrated. And then the last thing is one that I often forget and we often forget to do, and that's the ability and the opportunity for the client to give us feedback. And that has been shown to improve our work as therapists when we allow the client the ability and opportunity to give feedback. And I struggled with this for a while because I thought, how do I get feedback without making it about myself? So some people have different things. They have rating scales, they have that sort of thing. But I've gone to just asking the general question, what was this session like for you? Now that forms and forces mindfulness, but it also gives them an opportunity to say anything they want to say about the session. And it doesn't seem to make it about me. It seems to make it about what's going on with both of us. So I really like that question. It's really seemed to help me in bringing out things from clients is, what is this session like for you, or what was this session like for you? When I talk about the Therapeutic Alliance, I'm talking about the process is more important than the content. So what I say is the music is more important than the lyrics. Alan Shore, psychologist, refers to therapy as a right brain to right brain activity. And I like this look as well because we are one person to another person connecting with one another. And it's that's one of the main things about healing. Now, I didn't know this when I first started in psychiatry. I thought the more I would know about different forms of therapy, the better I would be as a practitioner. My residency director was telling me, no, that's not the case. It's really the process more important than the content. I didn't believe him, but over time I've come to realize that's really the case. The content is important, but the process of what's happening between us is the most important. Now, the number one way to increase the therapeutic alliance is get therapy yourself. We all need our own therapy. We all are wounded individuals. We all have gone through our own trauma. And we all need to know what it's like to be a client or to be a patient. So I say that if you're not in therapy or you're not done your own work in therapy before, then go ahead and get therapy yourself, because otherwise you will be hurting the client and you won't even know it. You'll be unaware of what you'll be doing. You'll be unaware of your countertransference and transference reactions that are going on. So I say, please get therapy yourself, and also do it as often as you can throughout your career using different forms of therapy. I still, 38 years later, I've had a lot of time in therapy off and on with different types of therapy, and I'm still in therapy now, and I find that's very valuable. So really get therapy yourself. Now, these are the people that are my sources and inspiration. Stephen Porges with the Polyvagal Theory, Alan Shore, who wrote Affect Dysregulation, Peter Levine of Somatic Experiencing, Pat Ogden of Central Motor Psychotherapy. My favorite trauma author is Babette Rothschild, who wrote The Body Remembers and The Body Remembers Volume 2, as well as 8 Keys to Safe Trauma Recovery, which is a wonderful book for the client to have. Also, Kathy Steele, who is an expert in treating trauma-related dissociation. And then Christine, who was the head of the APA, American Psychological Association group on the trauma for a number of years. She wrote a wonderful book, Healing the Incest Wound. So these are just some of my favorite books that I like to refer people to. Now, what other means to increase the therapeutic alliance? One of them is we have to have our own sense of spirituality. And what do I mean by spirituality? I mean ability to tap into something that's positive, that is good, that is joyful, that is present moment experience, that is non-judgmental, and gives the client and ourselves a sense of being alive and creative. So we need to all use our own spirituality, but we also need to strengthen it over time. We also need, I think, to protect us from some of the things that occur in working with the clients with trauma. We do have secondary trauma issues that come up from the difficult things we work with people. And I also want to talk about the issue of evil. Now, this is an area where not everybody will agree with me. But what I say is, if you feel that evil is just an abstract concept and not a real reality, then it's best probably that you not work with people with developmental trauma, because what they have experienced in many cases is true and genuine evil. And you will hear about this when you hear the stories. There's a great thing that Kathy Steele has written. She wrote an article called Sitting with the Shattered Soul. And what I've done is so important, and I appreciate it so much. I'm going to take an excerpt of that and just slowly read the whole thing. I can take it now without crying, but I used to cry every time that I read this. She said, "So how do you sit with a shattered soul? Gently, with gracious and deep respect. Patiently, For time stands still for the shattered, and the momentum of healing will be slow at first. With the tender strength that comes from an openness to our own deepest wounding and to your own deepest healing. Firmly, never wavering in the utmost certainty that evil is powerful, but that there is a good more powerful still. Stay connected to the goodness with all of your being, however it manifests itself to you. Acquaint yourself with the shadow that lies deep within you, and then open yourself, all that is in you, to the light. Give freely, take in abundantly, find your safety, your refuge, and go there as you need. Hear what you can and be honest about the rest. Be honest at all costs. Words won't always come. Sometimes there are no words in the face of such tragic evil. But in your willingness to be with them, they will hear you. From soul to soul, they will hear that for which there are no words. When you can, in your own time, turn and face that deep chasm within you. Let go. Grieve, rage, shed tears. Find those you trust and let them be with you. Know laughter, the healing power of humor. Trust yourself. Trust the process. Embrace your world, this world that holds you safely now. Grasp the tender mercies of the moment. Let you be loved. Let you love. This shattered soul will heal. I just think that's wonderful, and I think Kathy Steele is just a wonderful therapist and a wonderful teacher. So any of her works I recommend to you. The only thing I would have different from Kathy is I don't think people are actually shattered or broken. I think of them as wounded. So people come in and they often think, they say, well, I'm broken, I can't be fixed. And I like to think of them as being deeply wounded, not broken, because wounds heal. And I like to emphasize that with people. Also, what are some of the things we can do that just, I think, help a little bit? The first one here is not one that everyone will agree with me, but I think we need to have good lighting. I've been in a number of therapist offices where the lighting is fairly dim, and this makes for somewhat of a cozy setting. And I know a number of you probably like that and feel more comfortable in that setting and feel that's best for the client. I think it's a little bit difficult because we then cannot see the details of the client's facial expressions, the client's face, the minor changes that indicate there's some shift in what's going on inside them. And with good lighting, we can see those things. We can see those shifts, which are usually manifested in minor changes in facial expression or facial movement. Another thing I think about is the type of seating that we have. I've been in many therapists and psychiatrists' offices where the therapist is sitting in a chair and I'm sitting in a couch that's sitting well below the therapist. I think we need to be at approximately the same height. We need to be eye to eye as much as possible. And this is not easy for those therapists who are very tall, but we need to try it as much as possible. Why is that? And that is because when we're hovering over or we're over the client, it's more like what they may have experienced in life, that somebody is over them and intimidating them in some fashion, and we will appear unconsciously intimidated to them if we're seated much higher. They will feel one down and never even know why they're feeling that way. The other thing I emphasize for therapists is start and stop on time. This is one of our biggest things. We go over time. We have clients wait. This is very difficult. We are now used to going to see doctors and attorneys and dentists, and we're all used to waiting. So if you start on time and stop on time, the clients will appreciate that. And when I talk to clients about one of the things that they really appreciate about therapists, they always come up with one of these things being start and stop on time. Now, there's occasional time when you will go over, and this can't be helped. But there are a number of therapists, there are a number of clients who wait until the end of the therapy session to bring up something very important. And if this comes up on any routine basis and you have to feel like you need to go over, then there's a countertransference transfer issue that needs to be addressed with you and that client. The other thing is therapist presence. A number of therapists, and I used to work and see one client after the next, after the next, after the next, after the next. And this is great in one way, so we can see a lot of people. But I don't think when we do this, we can actually be fully present with the client in the session. We have to have some time in which we, during the day, have rest for ourselves, have time off for ourselves, have time to regroup and regather, so that when we're with the new client, we can be fully there with them. And I think this is one of the most important things I've tried to learn over time and still learning is, can I be present with the client in this session? And so I made to make sure that I eat well, that I sleep well, that I take care of myself so that I'm not feeling sick or ill or tired or fatigued when I'm working with one of the clients. Now, the other thing about the therapist presence is I figure out some ways to try to do that. One thing I do is to wish the client well before they come into the room and as they're walking into the room in my mind, not to say that to them. And in my spiritual background, that means to pray for them. So I pray for them and their well-being and my ability to be present in each session. So strengthen your spirituality, but be yourself. When I've learned from different therapists, I've tried to copy them. And it really, you can't be anybody else. You're just yourself, and you need to use yourself and yourself as your instrument as best as you can, using the things that you've learned from more experienced therapists. I'll give an example. When I was first out of psychiatric residency, I worked in a modality of therapy and was learning intensive short-term dynamic psychotherapy, which was taught by Habib Davanloo, who was a psychiatrist who was Iranian but lived in Canada. And we did all our training with videotapes. We didn't bring anything in except our videotapes, and we'd watch videotapes of him and other therapists. And what I found myself doing for a while was talking with my clients with an Iranian accent. So it took me a while to realize that I was doing that, and I just really needed to be myself. And the other thing to really emphasize is love your clients, want the best for them, treat them exactly the way that you would like to be treated yourself. And most of us don't like to be confronted. Most of us don't like to be involved in situations where we may feel shame. So do your best to treat your client just the same way you want to be treated yourself. Now, I want to talk a little bit about what I call the problem of the other. The problem of the other is this, is that we are designed or we develop with what I refer to as tribal brains. For thousands and thousands of years, our brains developed in groups of people of 150 to 400 people around that, seeking and competing for the same sources of space, food, water, territory, resources, that sort of thing. So many things have changed in our society, but our tribal brains have not. They are still tribal brains. And what we will do is anytime we make someone an other outside of what our own defined tribe is, we will mistreat them, we will abuse them, we will cause harm to them, we will damage them, and we will hurt them. And a lot of this will be unconscious. And I'll give some examples of that. I am male, you are female. I'm white, you're a person of color. I'm straight, you're gay. I'm German, you're Jew. We always mistreat other people when we see them as others. So I like the principle of unity, that we're all the same and we're all in the same boat. There is no other. Often another example would be, well, I'm a therapist and you're a patient, or I am normal and you're borderline, or I am normal and you're mentally ill. Those are other ways we make others. And that causes a great deal of shame. Now, we unwittingly will shame our clients, and we have to be ready to make apologies when needed. There are many times when the clients are angry with us, and it's their own issue, but many times they're angry with us, and it's really because of what we've done or what we've said, and we need to make apologies. The most striking example of that I ever had was I was working on a residential unit with a young woman who engaged in a lot of self-harm behavior, a lot of cutting. And we talked in our first meeting together that we needed to use the impulses and the urges to cut as signs of increased anxiety and things that we needed to examine further. She was very afraid that if she told about cutting, that she would be sent back to our inpatient unit and lose the therapeutic relationship that she had with the residential team. Now, stupidly, and for dumb reasons, I don't know why I said, oh, well, that's not going to happen. We'll make sure you stay here in residential treatment. Just let us know, and we want to be aware of what's going on. And that wasn't very bright of me, because one night I was on call, and I got a call from the from the charge nurse, who said this particular individual had cut themselves very deeply. Now, the other cuts were mostly just superficial. And so I said what I had to do at that time was to say, well, we have to protect her. Let's go ahead and send her to the inpatient unit for protection and monitoring very closely. So when I came in the next morning, she was furious with me. She was yelling at me, she was screaming at me, and she said, Dr. Seymour, you betrayed me. You said I wouldn't have to go to inpatient unit, and you sent me here. You betrayed me. Now, all of myself wanted to defend myself in some way. I wanted to say, yes, but I had to, or something like that. But something inside me stopped. I don't know what it was that stopped me. But I simply said, you know, you're right. I did betray you. I'm very sorry. And then this individual started to cry. And I asked, why are you crying? And she said, I've never had anyone who's done harm to me ever apologize for what they've done. And then she looked at me and she said, can we still work together? I said, yes, of course, of course. So it was a genuine apology without self-serving, self-defensive protection that allowed her an experience that she never had before. Now, I want to talk a little about a paradigm shift in looking at work with patients. For 100 years, 120, now 120, 130 years, we've always gone by what I refer to as the psychopathology model. That is, we wanted to know what's wrong with the patient, what's wrong with the client, how do we compare them to other people who have the same type of difficulties, how do we label them, how do we group them in groups together so that we can study them and we can find ways to help them. If we don't group people in groups and learn things like we'll call this major depression, we'll call this schizophrenia, and we'll call this bipolar disorder, we'll call this post-traumatic stress disorder, whatever it is, we've used that model because it's been very useful for research, and it's been very, very useful in terms of helping us find certain kinds of therapies and modalities that seem to help patients with certain kind of problem. But I think that time has really passed. There are things as serious mental illness. There is schizophrenia. There is bipolar 1 disorder. There is severe obsessive compulsive disorder. And yet I consider those as brain disorders, not psychiatric disorders. They're included in psychiatric disorders because they have strong behavioral manifestations. But I think of those as not being psychological conditions, but being neuropsychiatric brain conditions that we definitely need to treat in specific ways, but the causes of them not the same as our other problems. So what I like instead is the neuroregulation model. And this means there's the oversimplification comes down that most of our difficulties come down to two things. The first thing is difficulty regulating our nervous system. In other words, difficulty dealing with anxiety. And the second is difficulty in managing and navigating interpersonal relationships. And what we find is that the difficulty in managing regulation is directly linked to our ability to navigate interpersonal relationships. And I'll give some of those examples. If we think of our clients and who have the most dysregulation, the most trouble handling anxiety or managing feeling states, are those clients who have what we refer to as borderline personality disorder. Now, I don't like to think of the idea of a personality disorder the way we look at it in DSM-5, because they're categorical diagnoses, and our personality is much, much more complicated than categorical diagnoses. So when somebody says so-and-so has a borderline personality disorder, I think not in terms of personality, but they have what I call maladaptive coping mechanisms to deal with severe neuroregulation that is often secondary to trauma and or genetic factors. So that we're really looking at the person that's having difficulty regulating their system, and as we help them do that, their interpersonal relationships automatically will get better. Now, there has been a few studies looking at this. One of them I like had to do with taking people who had so-called borderline personality disorder and have them in a room and a control group of psychiatric patients who did not have the diagnosis of borderline personality disorder in another room. And then a stranger was introduced into each room. Vital signs were monitored. And what it turned out is that the longer that the stranger was in the room with the person who did not have the diagnosis of personality disorder, the calmer they tended to get. They were able to speak to one another, talk with one another, and put themselves at ease. The opposite was found in those patients with the so-called borderline personality disorder. The longer they were with the stranger in the room, the more dysregulated they got. And this is really important because it's a physiological manifestation or physiological proof of why the basic thing we look at with people with this kind of problem is, I hate you, don't leave me. They simply do not have the capacity to stay regulated in a relationship very well. And that leads to many and many of the difficulties that we see. So I like the neuroregulation model, which says we're looking at how we manage anxiety, manage emotions, and this will help improve our interpersonal relationships. And I think the neuroregulation model is a lot of what's used in dialectical behavioral therapy. We're looking at distress tolerance skills, mindfulness skills, emotional regulation skills, interpersonal communication skills, and interpersonal personal effectiveness. And I think so a lot of the DBT skills that we learn and we help our clients learn are based more on the neurologic or neuroregulation model. The other thing about this model is it's positive looking. We're wanting to know what's right with the client, not so much what's wrong with them. So again, as I mentioned, there's problems in nervous system regulation and problem in navigating relationships and the link between them. And one of the ways to understand this link is to understand the Polyvagal Theory developed by Stephen Porges. Stephen Porges was a neurological researcher who worked with infants and young children in terms of developing monitoring systems for their nervous system. And what he proposed was there's a link between the problems in nervous system regulation and problems in interpersonal relationships, and they were based on what were differences in the autonomic nervous system. So I refer everybody to the wonderful book, The Polyvagal Theory, but it's a little bit dense and it's a little hard to read. So he's written another book, which is it's a pocket guide to the polyvagal therapy, polyvagal therapy. And another author, Deb Dana, who's worked with him, has won the polyvagal theory in clinical practice, which is very, very good book to look at. Now, when I say starting with what is right, here's what I do when I meet with a client for the first time. I've got their background information. I know what's wrong with them. I listen to them and they indicate what problems they have, and I try to understand what their difficulties are. But the first assignment that I give them always starts with what I call a resource assignment. It starts with what is right with them, not what is wrong. It starts with the idea that we're looking at things that have been resources in their lives that they can rely on. So one of the questions that I start with is, what are some of the things that you're proud of in your life? What are some of the things that you've accomplished? You hear some amazing things from clients with this that you never would have imagined, that they really start to feel proud of. Now, if you allow them to experience that and have it sink in and sit with them, they begin to have a decrease in shame and a greater sense of self-efficacy. Another question I ask them is, are pets been important to you in your life? A lot of people have difficulty with interpersonal relationships, but they do have strong relationships with their pets, and they're able to see through them the capacity to love and to be loved, even when that's difficult with people. I also ask them what places they've enjoyed going, what places they've enjoyed visiting. And what I look for is when they tell me, I look for what I call the magical moments. Every now and then when we're on a trip or going somewhere, we have a certain moment that just strikes us as being a magical moment. And I think of this as we're really in touch with the present moment, with what we're experiencing at that time. And it seems magical, it seems spiritual, it feels enlightening. And most people who have been traveling do have that kind of experience. And to help the client touch into that is very, very valuable in terms of reducing their anxiety and reducing their shame. Another thing that I ask them is who in your life has most understood you? Who's really got you? Because what we want to be is we want to be understood in life, but we really want people who really, really, really get us. And that's often very, very few people. It's the people that really, really, really get us that we feel safe with. And a number of our clients have never had a felt sense of safety. They know when they should feel safe. They know intellectually when they're safe, but they never had a felt sense of safety. And a lot of times, linking them in and touching base with them in terms of who really understood them, who really got them, that really helps settle the system and improve their ability to see positive things in themselves. Often I find this is a grandmother or a grandparent, sometimes more often than the parents. Sometimes it's a spousal partner or romantic partner. Sometimes it's just a friend from the old days. But we want to touch into someone who really gets us. And then I can talk with them about what do they really get about you? What do you really feel that they really have for you that other people don't? Then I also ask them a question about what they would like to say to other people in their own position. This is what would you say to someone who's in your position? And all this is stuff that is written down in between the first session and the second session. So they come in and we answer these questions on the second session. But they write down what they would like to say to somebody else to encourage them. And these are the things that are really good for them to write down because it really turns out they would encourage themselves. And the last thing I ask them is, where would you like to see yourself 5 years from now? And the reason I ask that question is because a lot of people with trauma and post-traumatic stress disorder and related disorders have a foreshortened sense of the future. They really can't see the future. They're living in the past. They're stuck in the past. They're stuck in the things that are wrong and have happened to them. They relive that over and over again, and the future is just not there for them. So by asking what they'd like to see for themselves in 5 years, I get them to not only look towards the future a little bit, but also gives me an idea of what's really important to them and gives them an idea of what they really want to work towards. So all of this is included in what I call the paradigm shift. We also have a non-labeling. We do have to use DSM diagnoses for insurance purposes and communication with other therapists, but I don't like the idea of using labels. They tend to put people in boxes, and we are not boxes. We don't belong in boxes. So we have general ways we look at things, but we don't like the label. Also, a very non-judgmental attitude. And this is hard for the clients to receive, and it's hard for them to have for themselves, and it's hard for them to believe that that really can occur. But if we take a non-judgmental attitude towards them, they can begin taking a compassionate, non-judgmental attitude towards themselves. Again, I've said this is non-violent. We don't want anything to ever confront the patient. We want to clarify. We don't want to take away their defenses. We want to increase their choices. We don't want to interpret much for them, but let them interpret things themselves. And as I said, we want to look at their strengths and their resources. Now, being someone who works a lot in somatic therapies, when they're tapping into their resources, we really look at what they experience somatically. And what I'm looking for them is to experience the sense of warmness, light, positivity, or actual joy. Because when we're talking about some of the people that have understood them in their lives, and we go to noticing what they notice in their body, they often notice there's a warm sensation that they can stick with and sometimes spreads. Occasionally, they will touch into some episode of true and genuine joy. And when I see this, I tell them that this joy is the opposite of the trauma. Calm is great. We like calm, but calm is not the opposite of trauma. Joy and light and goodness is the opposite of trauma. So the more we can help them tap into the sources of joy, the better. So that's all I'm going to say today. I think I'm not going to really talk about the window of tolerance. I think this is well known by most of us in that we operate generally within a good range of activation or deactivation. And this was a concept by Dan Siegel, who wrote Mindsight and other books. We function best when we're within the window of tolerance, and we need to guide our clients into moving out of excessive hyperarousal and excessive hypoarousal, i.e. dissociation and depression, into a zone of relative more regulation. So we'll stop here for today. These are some of the references that I have. The last one is a little bit tongue-in-cheek as I'm working on some work myself. But these are some of the resources, and you'll get other resources in the letter that we'll mail out to you. So now I'll just ask if there's any questions. Let me get to the okay. We have a number of questions, and I have to move up close because I can't see very well on the computer screen. Do you send them home to write out their answers or ask in session? Send them out to write down their answers and then ask them in session. And then when you're asking them in session, always, I do this as a somatic therapist, tend to see what they experience in their body when they're talking about these positive things. And that gets to take them into the body with warm sensations and not just in their mind. So they do it as homework and come back and bring it in. How do I work, another question, how do I work on being non-judgmental and not applying labels? That's hard. That's hard because all of us are judgmental to some degree. We're judgmental to ourselves, about ourselves, and we're judgmental to others. I think the best way of being non-judgmental and not applying labels is to learn to do that for yourself, to be non-judgmental, to have great compassion for yourself as an individual. And when we have compassion for ourselves and a lack of judgment for ourselves, then we're really able to be non-judgmental very easily with other people. Let's see, another question is, how do you work with someone who has never had a trusting, empathic, understanding person in their life? This is, unfortunately, it's very common that some people have never had that. They've never had the felt sense of safety. And so what you try to be is as open as you can and as non-judgmental as you can. They still won't feel that safety very easily. One of the things that they will know maybe intellectually that you're a safe person as you talk with them and they can trust you. But here at Sierra Tucson, the best way for people who have never had this to get a sense of safety that they really feel is an equine therapy. We do have equine therapy, and a lot of times when these people are able to just touch and be near the horses, the anxiety level comes down, and the first time in their lives they may have felt safe in some way. So I think equine therapy is very valuable for someone who's never had a trusting person in their lives. Let's see. Please elaborate on the idea of what you would like to offer someone else. I'm very sorry. I'm not sure what this question means. I apologize. I'm sorry about that. Okay, what is your favorite book to suggest to your trauma clients? The two books I recommend is The Body Remembers by Babette Rothschild. This is a book which is similar to Bessel van der Kolk's The Body Keeps the Score, but that book is a little bit dense, and I don't really know people and our clients who have finished that book. The Body Remembers is a nice short book that's easily readable and tells the basics about the autonomic nervous system and how that plays into trauma. The next book I like is also written by Babette Rothschild, and that is 8 Keys to Safe Trauma Recovery. 8 Keys to Safe Trauma Recovery by Babette Rothschild is the best book I've ever seen for clients to use themselves, to use with you in going over the topics and to use themselves. And it really gets into nitty-gritty, such as how in the world do I deal with flashbacks? Those type of really practical things. And I like Babette Rothschild because she has a lot of common sense and she gives common sense answers and nothing that complicated for patients to understand or clients to understand. So that's the book that I would give them first. Let's see. Could you send that list of questions you asked people to write for the next session? Yes, I'll do that. We'll attach that resource assignment to the letter that we send out to you. I think that might be helpful and certainly use it. I borrowed it from somebody else who was a therapist here. I borrowed it from a man uh, uh, that used to be a therapist here and liked to focus on people's resources. I modified it a little bit, and you can look at it and modify it yourself to something you figure that would be better suited to you because we're all a little bit different. How do you forgive yourself for promising something to a client that cannot be delivered? Oh, you're experiencing. Oh, that is very, very difficulty. It's hard for me to forgive myself. And the thing is, we all make mistakes, but that one that I talked about, that was a really big mistake. It's just hard. Um, I have to learn that I'm a person like everybody else, that I'm not perfect, that I have my flaws and my faults, and have compassion for myself. I'll tell you another mistake that I made one time, and that was as I preached to people about the problem of the other and not making an other of somebody, a woman that I saw caught me in doing that very thing. We had a woman who had psychosis, probably diagnosis of schizophrenia, that was in a residential unit. And those people don't do very well in residential unit because we have high levels of emotional intensity there. So she wasn't my patient, but I did see her because she needed to see somebody when she was agitated. So I brought her into the room and we started talking, and she became increasingly agitated, paranoid, and threatening. So I did what we're told to do in those situations is I got out of the room and invited her to come out of the room, and we got in a general lounge area where there were a lot of people around and a lot of staff around. So with a lot of staff around, she did what a lot of people do and kind of calm down. And we talked a little bit, and then we talked about, we'll give you some medication, let you go to sleep, and then I'll come back and we'll talk a little bit later. And I turned and walked away. She said, Dr. Seymour? I said, what? She said, aren't we going to have a proper goodbye? And I had treated her with less respect than I would someone else because unconsciously I saw them as different because I'd labeled them as schizophrenic in my mind. So even though I preach about this all the time, I always don't practice what I preach. Let's see. Do you have recommendations for applying this approach to neurodivergent clients? I'm sorry, I don't really know what you mean by that. I apologize. I should know what you mean, but I don't. Um, are you talking about people who have neurological problems or people who have developmental disabilities? Oh, neurodivergent, ADHD, and autism. Oh, same approach. Um, Same approach as everybody else. We don't want judgment. We don't want confrontation or violence with them. We want to give them choices always. We want to give them an opportunity to express themselves and listen in a trusting manner. So I don't think we really do anything different. I'm not a specialist in autism though, so there are probably some specific things that need to be done differently for those with autism. Do see a lot of people with attention deficit hyperactivity disorder as well as other problems, and I just treat them and they respond the same way to the general approach. Let's see, are there any other questions? One question I have that I see is how can I understand really what you mean by nonviolence? And again, the nonviolence concept is that you don't do anything that would cause shame in the client. That's the thing you're really looking for. Our clients invariably will experience shame. They'll experience shame when they talk about the difficulties. They'll experience shame outside the session. They'll experience shame with us if we make any intervention at all. So what we have to do is just learn to decrease the possibility that we're shaming them. And so I used to set limits in a bad way. With some clients, we have to set limits. But I would do it always in a kind of firm way. And now I've learned to do it just a real quiet way, just quiet, giving them some choices and making recommendations and setting limits. And that seems to work a lot better. Well, again, thank you very much for the chance to let me talk with you. Again, I'm really proud that I'm one of an army of therapists with all of you all, and that we get to work together to make this world a better place, one person, one couple, one family, and one group at a time. Thank you.